right, guys, welcome back. I have another obstructive case for you. And as we've done a number of these at this point, from last unit doing a bunch of restrictive cases and now tackling a number of different obstructive cases, for this case, I'm going to turn it on its head a little bit, okay? So case number 13, as you see in your notes, I started with the medication. And the question on the slide is, what can you infer regarding the patient's diagnosis from their medication list only? I like at this point in the semester to try this and see if we can figure it out based on her meds, his or her meds. I'm not sure what the sex of our patient is yet. Because one, pharmacology is such an important tool that we have to use. And I think it's underutilized by PTs. We kind of stay away from pharm a little bit. But when you become comfortable with the drugs and the type of drugs that often are prescribed with different types of diagnoses, it can be incredibly powerful that you get a snapshot of a picture, how severe they are. Based on the dose of that drug, you can really tell kind of how intense that symptom that drug might be treating. There's just a wealth of information that comes from the meds. In addition, sometimes that's all you have. If it's outpatient and you say, anything significant in your medical history, and they say, no, not really, I'm pretty fit. And you say, you want any medications? And they say, yeah, I brought this list. Here it is. And these are the drugs that are on the list. You're going to probably decide that they maybe are underrepresenting their medical history in some way, shape, or form. So sometimes you really do have to infer backwards from the medication. So let's start here. Let's look at the medications and see if we can make some educated guesses as to what our patient's diagnosis might be. So they're on 2 different bronchodilators. Prednisone, so they're on an oral steroid. They're on an ACE inhibitor and a diuretic. If you're feeling engaged, see if you can pause the video and make a guess. Think about it for a second. See what you think. All right, so they're on 2 bronchodilators. So kind of what diagnosis might that be? So possibility of something obstructive, maybe COPD. Could be possibly cystic fibrosis with the double dose of bronchodilators. Could be asthma. Asthma would have bronchodilators. It's a little bit less common for an asthmatic to be on an oral steroid. More often, those asthmatics are put on an inhaled corticosteroid. So I would say asthma is probably less common, but a good guess for someone who's on a bronchodilator. Let's see, what else could they be on? So they were on bronchodilators, they were on a steroid. That's a really hard one to narrow down. Something inflammatory, chronic. All right, then I see an ACE inhibitor and a diuretic. ACE inhibitor and a diuretic. What comes to mind with those 2 meds on board? ACE inhibitor, blocking the renin-angiotensin system, diuretic, getting rid of fluid, highly associated with heart failure. So I'm wondering if that could be involved. ACE inhibitor is a blood pressure med, so it could be hypertension. Hypertension is much less likely to be treated with a diuretic. So the ACE inhibitor with the diuretic makes that a little bit less likely. The ACE inhibitor, the angiotensin system is highly involved in the kidney. So maybe they have some kind of chronic kidney disease with that drug being on board. Definitely a possibility. So just from the meds, we're kind of starting to fill in kind of expected things that might be on board for this patient. All right, before the great reveal to see how well we did with our diagnosis, let's talk about these meds a little bit. So I've been trying to create this little mini pharm reviews along the way, and there's a couple new drugs in here. Let's talk about them. Let's first hit on the bronchodilators. So this patient is on two separate bronchodilators, And one is a long-acting muscarinic inhibitor, and the other is a short-acting beta-2 agonist. So a short-acting inhaler is sometimes called a rescue inhaler. The drugs that are delivered in a rescue inhaler usually has an effect within less than 5 minutes. So patients take 2 to 4 puffs, and within about 5 minutes, they're going to have an effect of bronchodilation. So the effects come on quick, but they don't last particularly long. So they last about 4 to 6 hours. So some common short-acting inhalers would be like a beta-2 agonist. So again, if we go back to what we know, what type of receptor is a beta-2 receptor, beta-2 adrenergic receptor? This is the receptor of the sympathetic nervous system. So what does the sympathetic nervous system do to the lungs? It bronchodilates. So a beta-2 agonist would be a bronchodilator. What other things does the sympathetic nervous system have a big effect on? It affects your heart rate. So this inhaler might cause some tachycardia. It can cause heart palpitations. It can stimulate muscles and almost give like a tremor type feeling. Those are some of the side effects of a drug that is activating the receptors of the sympathetic nervous system. Our anticholinergics. Cholinergic receptors respond to acetylcholine, the primary neurotransmitter of the parasympathetic nervous system. So you're blocking the parasympathetic nervous system with the goal being bronchodilation. So a short-acting inhaler is based on the time. We want a quick action, but it can be either a beta-2 agonist or an anticholinergic. A long-acting inhaler takes longer to be effective. So it takes 30 minutes before you'd get the effect. So if you are having an acute respiratory issue, such as an asthma attack, you do not want to wait 30 minutes before you get the bronchodilation. So a long-acting inhaler is not for acute dyspnea. But it takes longer to come on, but then it lasts 12 to 24 hours. So patients take a long-acting bronchodilator because this will allow them to rely less on their rescue inhalers. So it creates a longer duration bronchodilator. You might consider this their maintenance bronchodilator as opposed to the rescue bronchodilator. So it takes longer to become effective, but it lasts a lot longer. There are versions of long-acting bronchodilators that are both cholinergic and beta-2 agonists. So whether it acts on the sympathetic or the parasympathetic is not specific related to short-acting or long-acting. It's the mechanism of the drug itself. Of long-acting bronchodilators, Spiriva is the most popular. It's taken only 1 time per day, which is a huge benefit for patients taking pulmonary drugs. So it's a long-acting muscarinic antagonist, and that's probably one of the most common maintenance bronchodilators. So you can often attack the system from multiple different places, right? You can stimulate the sympathetic and block the parasympathetic. You can create kind of long maintenance bronchodilation, but then have the effect of having a rescue inhaler that can very quickly bronchodilate if the patient gets into trouble. How you deliver these bronchodilators, there's a variety of ways. The most common is the metered dose inhaler, or the MDI. So this is probably very visually familiar to you, or you even have one yourself if you're someone who has dealt with asthma. The MDI uses a propellant to aerosolize and distribute a medication at a set dose. So you have the medication within the canister, and the propellant allows you to aerosolize that drug so the person can inhale it. The big issue with the MDI, or the metered dose inhaler, is you need to be able to have good timing. You need to be able to time your inhalation with the pressing of the canister, because for this to be effective, you need the drug to actually get to your distal airways. It's really ineffective if all the drug just lands in your tongue and your upper airways. It will not have the same effect of having this kind of massive bronchodilator. So really young kids, elderly patients can have a really hard time, neurocognitive impairment. They might not be able to get this timing down to really use a metered dose inhaler effectively. So a really great fix for that is something known as a spacer. A spacer is a valved holding chamber. So the patient releases the drug via the metered dose inhaler canister into the spacer. And the spacer basically like holds that drug as like a standing aerosol cloud. So from there, the patient can just breathe in from the spacer. There's no coordination required. So the spacer like reduces the speed of the emitted aerosol. So they push the inhaler, the drug goes into the spacer, and the patient can just take 3 really nice deep breaths from the spacer and deliver that drug more effectively. So this can be a really popular option for young kids or older individuals who really can't get that timing down to get effective delivery of the inhaler. Another option is the dry powder inhaler, or DPI. The delivery method here is the medication is held in a capsule, and when you turn the disc to deliver your next dose of the drug, the disc cracks open the capsule, and then you breathe in a dry powder. And that's how you deliver the drug, with a dry powder inhaler. The last one in your notes is the nebulizer. And as it says in your notes, the nebulizer turns the liquid medicine into a mist. So it takes your medicine and it mixes it with saline, so you have this nice mist you can breathe in. So the nice thing with a nebulizer is, again, no coordination needed at all. You can just breathe in the mist and get the medication delivered. So for that reason, it can be, used with kids. It can be used with elderly. It can be used with patients on a ventilator. Unconscious patients can get nebulizer treatments. This is a much better medication delivery because patients are able to breathe deeper and slower. So you can deliver a much larger dose of the medication with a nebulizer than you could with a metered dose inhaler. The negative is it does take about 5 to 10 minutes of just sitting and breathing the medication to get your treatment. So that can add up with when you have a lot of other stuff going on medically. So inhalers provide all the convenience of easy portability, but they have some drawbacks with coordination and really being able to get that medication deep into the lungs and not being able to get as high of a dose. Where nebulizers have all the benefits of easy breathing, higher dose medication, but much less convenient and much less portable. So our patient was on a maintenance bronchodilator and a rescue bronchodilator. They were on prednisone as their steroid. As I mentioned in the beginning, can be really helpful if you start becoming comfortable with doses of medication. By looking at the dose of prednisone, it can tell you about the severity of the disease that they're treating with prednisone. It can give you an idea of potential side effects. So the bigger the dose, the more likely they're going to be suffering from poor wound healing, muscle wasting, if they've been on it for a long time, osteoporosis. So prednisone can be delivered over a pretty wide range. It can be as low as 1 milligrams, 2.5, 5. It can go up to 10, 20, 50 milligrams is a pretty typical range that you might see for prednisone. So it gives you an idea. 20 milligrams is on the higher end of that dose. The aprils are ACE inhibitors. So let's just talk about that med as just a quick review. ACE inhibitors are going to block the action of the renin-angiotensin system. So renin gets released from the kidney And that allows, the ACE enzyme is what converts angiotensin 1 into angiotensin 2. Angiotensin 2 is the active hormone of the renin-angiotensin system. It acts through the AT1 receptor, causes vasoconstriction, and in the kidney, sodium and water reabsorption that raises blood volume. So if you block this pathway, you can effectively decrease pressure by blocking the effects of vasoconstriction and blocking the effects of angiotensin 2 in the kidney. So if you can lower the blood pressure, you're lowering the pressure of the system that the heart is pumping into. So ACE inhibitors, one of their primary goals is to decrease cardiac workload. Prills tell you that you're in the ACE inhibitor family. It blocks the formation of Ang2 because ACE is the enzyme that converts Ang1s to Ang2. So major side effects are that you can lower the blood pressure too much. So you can get hypotension, you can get orthostasis, and you can get something known as the ACE cough. The ACE cough is actually a sign of a toxicity issue the patient's having with the drug. It's this dry, hacking cough. And if a patient gets the ACE cough, they won't tolerate this med. So they're going to have to be switched on to another medication. A lot of times they get switched to an angiotensin receptor blocker at that point. So an ACE inhibitor is trying to decrease the workload of the heart. Can you think of any other big drugs that decrease the workload of the heart? It could be helpful to kind of lump some of these together. Drugs that decrease the workload of the heart. Really big one, beta blocker, right? Beta blocker, you block the beta adrenergic receptors and decrease the work of the heart. Our calcium channel blockers can be drugs that are on board to decrease the work of the heart. Kind of starting to put some loops around those meds if you haven't already done so. So in the same category of drug is our angiotensin receptor blocker, and it really functions the same way. It just antagonizes the AT1 receptor. So instead of blocking the formation of Ang2, it blocks the physiological response to Ang2. So just like an ACE inhibitor, it can cause hypotension and orthostasis. It does not have the toxicity issues that the ACE inhibitor has. So a patient could be prescribed either one of these drugs. ACE inhibitors are much, much cheaper than angiotensin receptor blockers. So typically patients would start on an ACE inhibitor, and if they tolerate it well and it works for them, then they would stick with that unless there's some other medical reason related to the ARB use. The last one on the list is the diuretic. And let's just take a minute to talk about our diuretics. So in general, most diuretics primarily work by inhibiting sodium reabsorption. So water follows sodium. So if you block sodium reabsorption and there's more sodium in the urine, water follows sodium into the urine and it helps to pee out some of our volume. Of the buffet of diuretics we have to choose from, loop diuretics are the really, really strong diuretics. That is because they act at the loop of Henle, which is the site of the countercurrent multiplier. And I always mention that because it's one of my favorite things in physiology. And I normally get dead stares from the PT students because I don't think you guys thought this was as cool. But the countercurrent multiplier is when the filtrate in the nephron is going through the loop of Henle, and it gets incredibly concentrated as it goes through the loop. I'd love to talk to you all about it, but I'm remembering the dead faces I have gotten in previous years when I start to geek out about the countercurrent multiplier. So I will move on. But please know that because it acts at the site where we concentrate our urine, it is the most effective of the diuretics. So if somebody is on a loop diuretic, that is a big, big drug to really, really deplete them of their volume. The loop diuretics can deplete potassium. This is a really big one to put in your brain. Loop diuretics can end up depleting potassium. Potassium has huge implications on the heart because it's necessary for normal action potentials in the heart. So when patients are on loop diuretics, they can end up getting into serious heart problems. So oftentimes, loop diuretics are just prescribed with a potassium supplementation, but that would be something to check, kind of have that in your mind, kind of link loop diuretics with potassium because of this big problem with depleting the potassium. The other two are kind of the weaker diuretics. Thiazide is a weaker diuretic that can also deplete potassium. That's why the class of drugs that actually don't deplete potassium are named that way, potassium-sparing diuretics. But that is a weaker diuretic. So our patient is on triamterene, which is a potassium-sparing diuretic. As like a general rule, the patients who are on diuretics, kind of the main negative side effect is that fluid depletion can end up being a problem, like especially on the loop diuretics because they're so powerful. So their goal of the drug is to get rid of fluid, but they can kind of, go do too good of a job, and you can end up in a fluid depletion state. All right, are you ready for the big reveal? Bronchodilators, ACE inhibitors, steroids, diuretics. This is our patient. 62-year-old male admitted to the hospital with progressive respiratory insufficiency. He was first seen 5 weeks ago, and at that time, they discovered that he had chronic obstructive pulmonary disease and congestive heart failure. So we've got COPD and congestive heart failure. So we have the bronchodilators and the steroids and the ACE inhibitors and the diuretics, making sense with the medical picture that we have. Since the evaluation, the patient's condition deteriorated with increasing fatigue, dyspnea on exertion, and progressive respiratory insufficiency. And we already went through this patient's meds. The patient is 5'10", 240 pounds, and appears in respiratory distress using accessory muscles for breathing. Respiratory rate is 30. Yikes. Really, really working to breathe. Heart rate of 90. Blood pressure 170/90. And normal temp. So these are probably no longer new for you guys. I think since you were in PathoPhys after 2017. 2017, they updated the guidelines for blood pressure, but I think you guys have been on board since they've been here. So these are the cutoffs. Obviously, this patient is running hypertensive now with the blood pressure of 170/90. So I kind of cruised past his shape without really stopping here. So 5'10", 240. This gives you a BMI of 30.4. So we are dealing with an obese patient. And that respiratory rate of 30 is likely going to be a tachypnic pattern. Tachypnic would be fast and shallow. Hyperventilation would be fast and deep. So someone who's in respiratory distress typically would be presenting with a tachypnic pattern. So this patient's chest x-ray revealed a normal heart size, flattened diaphragm, you can see it on either side, and consolidation and infiltrates in the right lower lobe. These are the patient's arterial blood gases. So when he was admitted on room air, he had a pH of 7.26. Oxygen was 30. Yikes, yikes, yikes. So extremely tachypnic, but not making up the oxygen levels that he needs. Not breathing off the CO2. CO2 is 78, likely driving, right, this pH imbalance. So they very quickly put this patient on 2 liters of oxygen and repeated blood gases. And when they repeated blood gases on 2 liters of oxygen, you see pH improved, but is not normal. Oxygen levels got up to 60, but 60 is still not great. 60 is really where you start to hit the linear phase of the oxygen dissociation curve, and this is at rest. CO2 is starting to breathe some of that off, but that's still really highly accumulated. So this patient was put on CPAP. So CPAP is continuous positive airway pressure. So the patient breathes spontaneously, but there's a mild amount of positive air pressure during inhalation and exhalation to help drive that delivery. So at this point, what would be the lab values that you would want to check? This is your patient, you're doing your chart review. What are you zeroing in on? It's important to start to be able to narrow your focus, to know exactly what you want to check. Let's do it together. So I'd love to be able to do these as a group, and I would love to hear what you would think would be your top thing. There's a whole host that I would think would be really important here. Probably a big one for me would be BNP. BNP would help to confirm the heart failure, but also give me an idea of the severity, right? If it's an acute decompensation, we're talking about values above 700, and the higher the value, kind of the more severe the decompensation. So BNP might be really valuable. I would probably also be really curious about his cardiac enzymes. So somebody who is in heart failure is not maintaining cardiac output. If they're not maintaining cardiac output, and they're not maintaining blood supply to deliver the oxygen demand of the heart, they could end up in an imbalance between supply and demand, right? They could actually be causing a myocardial infarction. So I'd love to see if there was some kind of an acute injury going on that led to his acute decompensation. Based on the meds that he's on, I would at least want to take a look at potassium and maybe his other electrolytes. He's on that diuretic. He's on a potassium-sparing diuretic, but I would kind of want to see where he was here to know how much I had to monitor, if there's other things I would be concerned about. I would maybe want to take a peek at white blood cells, because if white blood cells are elevated, that might be a sign that he has some kind of infection. He had that infiltrate in his chest x-ray. So I would love to see if there's maybe something brewing that might be revealed with his white blood cell count. I might take a peek at his H&H, his hemoglobin and hematocrit. I would expect that to be normal for a patient like this. He hasn't suffered a bleed. He doesn't have any known cancer, in his background. If anything, it might be a little high, because if he's having really low oxygen, that would actually stimulate red blood cell production. I might take a peek at his creatinine and his bun. So if you're not maintaining cardiac output, the kidney is extremely vulnerable to hypoperfusion injuries. So if there was some episode of acute hypoperfusion, he could have ended up with an acute renal injury, which would complicate matters. I might, while I'm in there, take a peek at what his cholesterol was, because I'm always gathering, that's supposed to be an L, kind of looks like a giant E. I'm always gathering my cardiovascular risk factors as I go through. That's why I kind of went back and paused on the height and weight, because we kind of blew past it. But BMI is a really important one, because the more cardiovascular risk factors they have, the more comorbidities they have, the more likely they're going to have complications in their medical plan, and they might be treated more aggressively. So that would be something I would want to take a look at. Let's do the same kind of guessing game with pulmonary assessment. And part of the reason I'm doing this is that we've done this together so many times, and it's good to see if you can pull it forward. It's also so important to have an expected abnormal, so that when you're walking in the door, you kind of have a picture of what somebody with an acutely decompensated COPD and heart failure might look like. Because then if something is not fitting the picture that is kind of common with those pathologies and with their lab values that you found, it's going to jump out at you more than kind of being lost in a whole host of signs and symptoms. So having that picture in your mind is incredibly powerful. So if you feel up for it, pause the video and see if you can fill in. What would you expect to find upon inspection? Posture, chest, accessory muscles, lower extremity. What might you find on auscultation, palpitation, percussion with a patient with this diagnosis? So you can pause it, or maybe you're coming back from pausing it. I would really encourage you to try to think through and see if you knew the answer to these. So upon inspection, the posture of somebody who is in acute respiratory distress, likely to be forward flexed, rounded shoulders. COPD or chest, I'm kind of expecting maybe a barrel chest appearance. He had that flattened diaphragm on the chest x-ray. The diagnosis of COPD, I may be expecting a high anterior to posterior diameter in comparison to his transverse diameter. Somebody who has been put on CPAP is needing a lot of oxygen support. So I would really think he's probably going to have accessory muscles kicking in. So definitely increased activation if he's still acutely struggling to breathe. May or may not be hypertrophied. It's hard to know how chronic he had been in his difficulty breathing. Probably when I walk in, activation of accessory muscles, prominent clavicle. If I would look at breathing pattern upon inspection, I would guess this patient's going to be an upper chest breather. That flattened diaphragm is going to be really ineffective. Probably a prolonged expiratory phase. That's a classic finding in obstructive disorders. Lower extremities, they might have some edema because of the heart failure. All right, if you auscultate the lungs, what do you expect to find? This is somebody who is barrel-chested, likely, maybe decreased breath sounds with all that air. Possibly maybe some increased sounds or bronchial sounds in that right lower lobe because of the infiltrates. The fluid is going to make that sound really loud. Listening to the heart, we haven't gotten into this auscultation yet, but you might hear evidence of heart failure, which would be S3. You might have difficulty hearing the heart sounds because of all the air. I would expect that if I palpated, I would feel decreased diaphragmatic descent. There might be dullness to percussion in the right lower lobe. All kind of stuff I would maybe expect walking in the door. What about what this patient might do in response to activity? So on high oxygen support on rest, they were still really tachypnic on the higher oxygen support. Heart failure, not maintaining cardiac output. If you're going to give this patient an activity load, I would be expecting a higher than normal heart rate response. They're going to use heart rate to try to make up for the missing cardiac output. I would guess that there might be a sluggish blood pressure response because of the heart failure would make that less effective at really mounting that kind of hypertensive response to exercise. I am definitely going to be expecting this patient to desat, right? They're on really high oxygen support at rest. So that's going to be one of my primary things I'm looking for. So signs of hypotension, their heart isn't keeping up, signs of desaturation, a patient who is in heart failure and you might strain their cardiovascular system, watching for any signs of an ischemia at all, right? A mismatch between supply and demand. It might be a sign they're not tolerating that activity. All right, so the pulmonologist orders a lung volume reduction surgery. So lung volume reduction surgery is a surgical treatment that's meant to help with the symptoms of COPD. Basically, this surgery takes about 30% of the lung tissue out, and the goal is that this should maybe improve their breathing pattern. So before we go kind of further into this case and how this surgery may or may not help this patient, let's just talk about, when someone gets a surgery, they're going to describe the surgical approach. And this type of surgery can either be a median sternotomy or video-assisted thoracoscopy. So let's go through these different approaches so we have a feeling of what kind of information is important to discern when our patients have a surgery in the thoracic area. So the reason that a doctor might choose one surgical approach over the other is based on the anatomy that they're trying to get at, right? How well they can create anatomic exposure to get at the part that they need to do the surgery. Preservation of function, right? They want to be as minimally invasive as possible. And then a huge part of it is just the doctor's experience and training. So you might go to a smaller or more rural hospital and see, a much larger incision than you would at a training hospital. And that might just be based on the doctor's training. So the first one in your notes is the video-assisted thoracoscopy, or VATS. And this is the minimally invasive approach for cardiothoracic surgeries. This is a video-assisted scope. So they just would need a local anesthetic to be able to do this. And if you can see from the approach here, right, they have 3 different insertion places. They do not need to spread the ribs at all to get at the section that they're trying to get at within the thoracic cage. So they, in most hospitals, this is becoming the standard approach for thoracic problems like lung cancer, pleural problems, esophageal issues, and even some abdominal surgeries. The big benefit of going in with a scope is that you have way less pain when you're not spreading open the ribs, much shorter hospital stays, they don't lose as much blood, and when you don't cut in and spread the ribs, they have way fewer pulmonary complications. These patients get up, they get moving faster, they have a less severe inflammatory profile, they do much, much better. So the next approach is the median sternotomy. So when someone is having cardiothoracic operations, this is the most standard approach. It's midline, it's typically just inferior to the suprasternal notch. That goes just to below the xiphoid. The sternum is divided along the midline. Sternal retractors hold the edges open and allow the surgeons to have access to the heart and lungs. When the surgery is done, they would take stainless steel sutures and hold the sternum together. The wound is closed in layers, so they kind of relayer all the tissue back together. After a patient has a median sternotomy, there is a lot of fear about that wound reopening up. That the position at that sternal point, that there could be pressure and pulling on the sternum that could disrupt the wound. So most patients have some version of sternal precautions after a median sternotomy for about 6 to 8 weeks post-surgery. Now, what these sternal precautions are vary widely, and there is a lot of noise in the cardiopulmonary world about sternal precautions. I'm on all these listservs where people are constantly debating sternal precautions and trying to come up with better models because the evidence on this is just really weak. So historically, sternal precautions were way, way, way too conservative, and it's hard on PTs as we go through this list. These are kind of standard sternal precautions. You may end up in a clinical going forward, or you may have been at one, which was much more liberal in their precautions, which would be a good thing for PT. Basically, the patient can perform bilateral activities, right? Bilateral shoulder flexion and extension as long as they stay below shoulder level, and they can do just really gentle upper extremity isometrics. For 6 to 8 weeks after surgery, they need to avoid any horizontal shoulder abduction, external rotation, or scapular retraction, because that's going to pull open, right? Open the chest from the front, any of those activities. Anything unilateral, that's going to create shearing at the sternum is the thought there. lifting weights greater than 10 pounds, pushing or pulling heavy objects, heavy housework, driving a car. So what happens is patients who are on sternal precautions are instructed not to push off the bed with their arms in some cases, and it can make sit to stand incredibly difficult. So it is a huge barrier to mobility. And there's a whole movement to try to allow more aggressive weight bearing as long as it is symmetric on both sides, as long as the arms are close to the body and not pulling outward. So you will see wide variations on this, but you want to be familiar with your institution's sternal precautions and what your specific surgeon will allow to make sure you know how you can treat patients. The last on the list is the posterior lateral thoracotomy. As it says in your notes, basically you go from the fourth thoracic vertebrae around the tip of the scapula to about the fifth or sixth intercostal space. So because of this, the surgeon is going to divide through the lower trap, the serratus anterior, latissimus dorsi. They try to avoid the long thoracic nerve to try to preserve motor function. So they cut through a lot of muscle to get to where they're going. And that is something to be really cognizant of when you go to treat someone after they've had a posterior lateral thoracotomy. They do their best to preserve nerve function, but nerve damage can occur. The intercostal nerve damage is pretty common with this approach. So this point in our story allows me to talk about these different surgical approaches, but the patients who have surgeries that use these type of approaches, they are not all pulmonary patients, right? They may be cardiac patients. They could be something with the esophagus. Sometimes it can even be areas into the abdomen that are related. But anytime somebody cuts into the thoracic cage, there is a chance of respiratory complications. So irregardless of why they had the surgery, just the fact that they cut into the thoracic cage puts patients at serious risk of respiratory complications. The risks include atelectasis is incredibly common, right? Collapse of their airways. They can get a pneumothorax where they get air in the pleural space. Pneumonia is incredibly common because they don't take deep breaths after the surgery. If you're not taking deep breaths and airways are collapsing, secretions will accumulate in the airways. Bacteria loves warm, wet environments. So if you're accumulating secretions, bacteria can grow and you can end up with pneumonia. So getting patients up and moving, so they're physically active, which automatically makes them take a deep breath, encouraging the use of incentive spirometry, so they force themselves to take these nice deep breaths to prevent atelectasis, teaching them about splinting so they're more comfortable taking breaths and coughing are incredibly important because these are the serious complications from the surgery. Ultimately, this can lead to respiratory failure. Of patients who have thoracic surgery, about 15 to 20% will end up with one of these respiratory complications. Less common is like a prolonged air leak that kind of makes the list, but not nearly as common. And then I can't help myself but bring up a little anti-smoking message. Pulmonary complications decrease in thoracic surgical patients who quit smoking 4 weeks or more before surgery. So if it's a planned surgery, talk to patients about quitting smoking before. They will do better with their surgery. After the surgery, it's incredibly important not to smoke because it impacts healing. They will not heal as quickly if they're smoking. Other common complications that when you cut into the chest cavity, you can cause cardiac complications. About 10 to 15% of thoracic patients will have some cardiac complications that typically are arrhythmias or ischemia. And by far the most common complication after a thoracotomy is pain. It's just around the surgical site. They can have pain because of positioning that they were put into during the surgery. Chest tube placement is incredibly painful and causes patients a lot of discomfort. So a pain buster is something that, as a therapist, you love to see. It is this continuous infusion system that basically creates a local anesthetic right at the surgical site. So it's a local pain delivery right at the incision that can really help patients get through that acute phase. So anyone who's had a thoracic surgery, when PT comes in, we should be talking about splinting for pain. So taking a pillow or even their upper extremity and holding that incision site when they take deep breaths or when they cough. So a splinted cough technique. Incentive spirometry. Do not believe them if they claim they did it. Have them show you. And then when they show you, they will demonstrate how familiar they are with that equipment. And that tells you a lot about whether or not they're doing it. Functional mobility is going to be incredibly important. So the trick with incentive spirometry and getting patients moving is to really sell the patients on what they're doing. Incentive spirometry can seem like this dinky thing that their nurse keeps bugging them about, but really talking to them about the benefit of improving their chest expansion, that they need to get air in to clear things out that are accumulating in their lungs from surgery. This can decrease the risk of atelectasis, pneumonia, and even venothromboembolism. So we need to get people up, get people moving, get people taking deep breaths. All right, so our patient had lung volume reduction surgery ordered. So this is, again, removal of lung tissue. Let's just talk about this surgery. So the thinking behind this surgery, if you compare the normal lung to the emphysema lung, the emphysema lung is full of air, right? We've got increased volume because you've trapped all this air. The trapped air is actually compressing the normal lung tissue. So emphysema can be kind of patchy. You can get sections of your lungs that have really bad emphysema, but other sections can be relatively healthy. But when the emphysema areas of the lung are engorged with air, they actually compress normal lung tissue. So the lung volume reduction surgery, you can see they take a chunk of the lung out. They cut out this emphysematic portion of the lung. And by decreasing the lung volume, you improve the outward elastic recoil and airway patency. So the healthy lung is less compressed and more able to take in air. It's also a less expanded rib cage, has improved function of the muscles of respiration, so you can get more, room for the diaphragm to descend. So in many, many ways, this does truly work, right? If you take some of that out, you will have these benefits. So here is a chest x-ray before and after a lung volume reduction surgery. So a significant improvement. Look at the shape of the diaphragm. This, truly, like, physiologically would help a lot. The negative is this is what they have to do to the patient to get it done. It's typically a lateral thoracotomy. The patient's on chest tubes after. And thoracic surgery is hard on the lungs, right? We just went through all the thoracic complications that can happen even if their lungs are healthy. This is a patient who has very unhealthy lungs, and now we've added this huge strain to the system. The thoracic surgery is going to cause an incredible amount of fluid. That's why she has the chest tubes. They can get pleural effusions, pneumonia, atelectasis, pneumothorax. So there was this really big, the NET study, NETT study, looked at really the benefit of lung volume reduction surgery. And what they found was it's really not appropriate for healthier subjects because it can in some cases advance their lung disease, because this is so traumatic on the lungs that the lungs don't do as well. It's also really hard on patients who are super end stage. They would be kind of past the window where they would tolerate this surgery. So the best outcome is when they're kind of in the middle of the progress of the disease, and it's the best when the emphysema is in the upper lobes. So if you're kind of wondering why one patient might have been given this surgery and another not, those are some of the pieces that go into that decision-making tree. In general, they aren't doing this surgery as much because of this, because of how severe the surgery is on the patients to recover from after. So what else do they have? Another surgical option for COPD patients is a bullectomy. So a bulle is a blister-like air pocket. It typically forms on the surface of the lung, so you can see the actual picture here of all these air sacs. The term bleb and bulle really only discern the size. A bleb is typically somewhere between 1 to 2 centimeters, and a bulle can be anything greater than 1 centimeter. So once it's bigger, it's typically called a bulle. So this is very common that these form on the surface of the lungs. They're negative because they can rupture, and if the bulle would rupture, it can cause a pneumothorax. They're a negative because this air trapped outside of the lungs isn't doing anything physiologically, and it's compressing the normal lung tissue. So they can go in and they basically take like a stapled wedge resection and they just cut this out and remove it. And they can do that in a much less invasive way. Another really cool tool that they have to help patients are endobrachial valves. So endobrachial valves are a one-way valve. So they get implanted with a flexible catheter through a bronchoscope. So this is minimally invasive. And it allows air out, but doesn't allow new air in. So patients with COPD have a dynamic hyperinflation, and these valves allow air to leave the sections of the lung that are, overinflated with air. So the goal of the endobrachial valve is that you decrease compression on neighboring lung tissue. You decrease the formation of bulle and blebs. It really kind of has the same benefits as the lung volume reduction without the surgery. So these valves are becoming more popular because they really help patients in a less invasive way. They can be removed. They're not permanent. So you could put them in for a while and then take them out if they're no longer needed or if the patient is, in any way not tolerating the valves well. So our patient was given lung volume reduction surgery. When you're going to go treat this patient, things to keep in mind is that this patient was under general anesthesia. So that's going to be a larger stress response. It would be helpful to look at how long the surgery took, right? The longer they're under, the more complications they would have. Because this patient has a history of pulmonary disease and now they just underwent a thoracic surgery, they're very high risk for respiratory complications. So it's common that the complications are going to be found in the dependent lung that was dependent during the surgery. So if you can look at the surgical report about positioning, but you will often find that if they develop a pneumonia or you're hearing crackles, it would be in the lung that was dependent during the surgery. The anesthesia is going to cause cough suppression, which makes the atelectasis and the pneumonia more common. You're going to want to be watching their screen because when you open the chest cavity, you open the possibility of cardiac issues. So this patient has the heart failure. There wasn't any known history of arrhythmias or ischemia, but they're at risk just because the chest cavity was open. Even in the absence of the heart failure, they would be at risk. So keeping those things in mind and really making sure that the respiratory piece is really high in your ranking of things to address early on would be really beneficial to accomplish your longer term goals of mobility and discharge to, whatever facility you're hoping that would be the least, intrusive on their life. keeping these goals in mind early on can prevent the complications that are going to end up with them having a much more complicated medical story. So we're on the front lines of that, and we're the heroes of the respiratory system because we get them up, we get them moving, we get those deep breaths. We are pneumonia preventers. All right, I hope you guys enjoyed the lecture, and I'll see you in lab. Bye.